It's great to be here with you all. I have looked forward to this because I attended my first CAIRIBU meeting this past December, and I was really excited about the really specific research efforts that are being done in urology and aging and the breadth of those studies. So I was excited to be able to have this opportunity to present. Now, I am having to present at home, and I need your um, verbal feedback that you can see my slides. I think I just,
How you had them looked good. We were seeing just what we're supposed to see.
okay. And if there's, okay, I'm going to start my clock. It's 3:10. So you want me to go until 3:30, or when should I end?
Yeah, 3:30. If you can leave 5 minutes for questions,
Okay,
like 3:25, that would be good.
perfect. Okay. All right. So objectives here is going to be to do a really cursory overview of what Scott kind of introduced, like why is geriatric incontinence syndrome important, and why we need an infrastructure that's really specific to establish a clinical care pathway for the treatment of this problem. So, one of the key attributes of geriatric medicine is to preserve health, and therefore, healthy aging is our future. And it's a really prudent decision given that in 2040, the population over age 65 is projected to reach 78 million. So, I think that we have a lot of job security and focusing on really pragmatic research in aging. Our future in healthy aging is in women's health. It's important because we have succeeded in our country at increasing the life expectancy. From 1950 to 2016, the life expectancy has increased substantially, with women living an average of 81 years. And women really do make up the majority of all our older adults and are caregivers for most families. And so we have to prioritize their health as often they will not. Aging and health is also important because, as this chart demonstrates, more than 50% of older women, unfortunately, will live with disabilities such as poor physical performance, difficulty with function or executing tasks, dementia, or other cognitive impairments. A focus on healthy aging means that when we look from 2005 here on the right to the left at 2025, the orange area represents all of the growing research in women's health, but the tiny little green area is what studies we've been doing on older women specifically. So there's a paucity of knowledge on what we know about how to care for older women. And since they are going to make up the majority, we have to begin to emphasize this. So, if we're considering impacting the future of healthy aging and women's health, we must have incontinence at the forefront of our minds. In this chart on the left, we see a summary of 13 different studies, and it shows in the red box that after the age of 65 years, more than 50% of all women will develop some measure of urinary incontinence through their geriatric years. And looking towards our right, the red line demarcates that incontinence symptoms become more severe and bothersome with increasing age. So as I began my practice at Wake Forest, I noticed that some of my favorite older patients would do great with some standard therapies for incontinence treatment and some would not. And as I thought critically about geriatric principles and frankly learned them as an attending, um, I paid more attention to the physical differences in my patients and noticed that my patients were exhibiting differences in aging and physical performance. So those on our left have clearly visible mobility, disability, potentially with accompanying cognitive decline and functional impairments. And these are distinct from the highly active, appearing, strong, and independent women on our right. I also know that treatment approaches for incontinence care have not effectively evaluated aging, not age, as a differentiating factor. So, urogynecologists have been taught and propagated a one-size-fits-all approach. However, I have hypothesized that differences in the aging process of women on our left and those on our right likely impact success of our incontinence treatments. And then I discovered among geriatricians, as they became my mentors, that incontinence is a geriatric syndrome. So, to ensure that we're all on the same page, I would like to introduce the concept of the geriatric syndrome. And simply put, it's a multifactorial prevalent condition affecting older adults that has multiple different causes, multiple pathogenic pathways, and one manifestation. And in our case, it's urinary incontinence. So I want you to understand this principle. I'll quickly go through the conceptual framework that's been established for geriatric syndromes. So there is existence of shared risk factors featuring increasing age, cognitive and functional impairment, and impaired mobility that leads to these syndromes to include incontinence. Of course, you are probably more familiar with falls, delirium, functional decline as geriatric syndromes. The importance of them is that they lead to frailty, and frailty leads to poor outcomes, increased dependence, loss of independence, increased institutionalization, increasing disability, and death. So when I started my career, I committed to kind of solving this issue of, how is incontinence a geriatric syndrome? How is it impacting on how we're treating women with this condition? And I looked at this, I was trying to learn about what do we know about this? And this is a chart I made that looked at publications on the common geriatric syndromes between 1999 and 2018. As you can see, dementia, there's lots that we know and increasing knowledge about that. For falls, we know a lot of also about what's happening and to have some pretty standardized prevention strategies. But for incontinence, we knew very little. And that's where I dedicate my time. So thus far, we've developed treatments for women with urinary incontinence that range from non-surgical to surgical treatments, and we target women of all ages. However, the average age of women included in major effectiveness trials is, around 55. And so there's what we really know about how to treat these women is very scarce. So to ensure that we're all on the same page, urinary incontinence phenotypes include the well-known stress urinary incontinence. This is what happens with leaking, with coughing, laughing, sneezing, exercise, anything that increases intra-abdominal pressure. We should be familiar with urgency urinary incontinence. This is the incontinence that happens when there's involuntary bladder contractions. And this can include nighttime voiding. And there's functional incontinence. And functional incontinence is often mistaked for geriatric incontinence, more so because it happens in more older adults. But functional incontinence is when there's some temporary disabling event, such as a recent surgery on a orthopedic type surgery, or some other condition that influences a person's ability to actually stand up, walk, to go, and void. And this is very different from the geriatric urinary incontinence, or GERI-UI is how I'm going to refer to it, because that is a consequence of those multiple different factors, and it's specifically associated with leading to frailty. So it's important to know that geriatric incontinence is a distinct phenotype of incontinence. And the reason why, like, as I said, that we need to pay attention to it is because it is, like other geriatric syndromes, a pre-frail condition and potentially impacted by multimorbidity. So I'll quickly go through like what's happening with aging to impact on urinary incontinence. Well, aging changes the pelvic floor. So you know that there is increased incidence of muscle weakness and loss of skeletal muscle mass, known as sarcopenia. There are some structural changes in the muscle that kind of contributes to this. And there's also this abnormal accumulation of collagen in intramuscular and extracellular matrix. As I learned about age-related changes that may contribute to GERI-UI, I was introduced to sarcopenia by my gerontology mentor and learned that this represents 80% of older women in nursing homes. And there's age-specific analyses that reveal that sarcopenia is an independent risk factor for stress, as well as mixed urinary incontinence with aging. And women with metabolically unhealthy obesity also have increased risk of both sarcopenia as well as stress and mixed urinary incontinence. So, in summary, with aging, there's smaller pelvic floor muscles, there's weaker pelvic floor muscles, and therefore the pelvic floor of women, which has high impact on urinary incontinence, becomes less functional. So, to begin our investigations into why urinary incontinence is a geriatric syndrome, I created my own conceptual framework based upon the one I showed you earlier for geriatric syndromes. And this has helped to organize the data that we already knew, which was that in aging women, there's increased incidence of urinary incontinence and there's increased incidence of functional impairments and sarcopenia. And then the dotted line is what we don't know. So how does functional impairment and sarcopenia lead to urinary incontinence? We started with women of the Health ABC cohort, a cohort of healthy, previously continent older women who underwent functional impairment evaluation. And what we learned was that in this diverse cohort, 33% of older women, and this was defined as older than 70 years, developed urinary incontinence when observed over 4 years. And older women who developed urinary incontinence also had significant declines in their physical performance, indicating functional impairment. The most impactful driver of this decline in function was significant decline in standing balance that was measured by the short physical performance battery. And last, older women who developed urinary incontinence also had a twofold higher risk of concomitant development of significant weakness, defined as sarcopenia. Our study findings were supported by this secondary analysis that also shows that those with urinary incontinence in red had more significant decline in physical performance as measured by the short physical performance battery compared to women without incontinence in the blue. So we learned that as women age and develop urinary incontinence, they become more functionally impaired and weak with significant changes in balance. Mobility is also impacted with balance, as indicated by this cross-sectional study of older adults with overactive bladder that shows that slower gait speed was associated with higher likelihood of urgency urinary incontinence. So it's not that so with functional incontinence, the argument was made that, okay, that they have, functional incontinence and geriatric incontinence are the same because they both have a gait speed problem. But the gait speed problem with functional incontinence is something that's iatrogenic, while the gait speed slowing with geriatric incontinence is an inherent condition reflecting from these processes that we've spoken about in poor muscle aging. I'm just going to skip ahead for the sake of time. So consequently, my conceptual framework had to change as the urinary incontinence that develops with aging is interdependent and associated with a potential accumulated effect of impairment in multiple systems, which is the definition of the geriatric syndrome. And this was evidenced by data that shows that physiologic depletion in estrogen after menopause causes loss of urethral smooth muscle, skeletal muscle, resulting in shortening of the urethra. There's functional impairment, has been shown to be present in 62% of older women with daily urinary incontinence. Mobility impairment features lower extremity weakness that has twofold higher prevalence among women with urinary incontinence and falls. In addition, there's decreased physical activity associated with increase in urinary incontinence. We discussed the issues with balance. And then finally, there's a 1.4 higher risk of cognitive impairment among older women with urinary incontinence. So this is a very different model than the linear model and gives us a more realistic understanding of how all of these impairments and changes can, in the same person contributes to the outcome of geriatric urinary incontinence. So next, we designed a prospective cohort study aimed to characterize geriatric incontinence and to understand its impact on the effectiveness of the primary way that incontinence is treated clinically, which is behavioral with pelvic floor exercises. You can understand that with weaker, smaller muscles, potentially pelvic floor muscle exercises are not going to be that highly impactful, but it had never been studied to date. So one of our initial reports was to clinically characterize geriatric incontinence. And what we learned is that the majority of women had a more severe type of incontinence, and this was significantly associated with functional impairment. To follow, we conducted a prospective cohort study, whereas 70 women older than 70 years were seeking treatment for incontinence and underwent a comprehensive geriatric assessment, as well as they underwent 12 weeks of pelvic floor physical therapy and behavioral treatment for their incontinence symptoms. And we observed that with impaired physical function, there's increased incontinence severity. And we also observed that after 12 weeks of physical therapy, there was no significant decline in their incontinence symptoms, despite the presence of physical function impairments. Pelvic floor physical therapy just did not work to decrease urinary incontinence symptoms in older women. So then, as a part of the deficit accumulation model for geriatric syndromes and frailty, our next study examined the distribution of the number of impairments present among the same cohort. And we learned that with increased urinary incontinence severity shown in the darker gray, it was more common for them to have, 4 geriatric impairments present. And this in figure B here, it demonstrates the categorized counts of the cumulative geriatric impairments as we were trying to really hone in on how we identify these patients in clinical practice. And we see that, with increased urinary incontinence severity, there is, this area between 4 to 6 geriatric impairments that are present. And we did this work in order to try to give a definition to geriatric urinary incontinence, similar to how we have a definition to frailty. So we next examined Medicare data to explore the role of frailty in treatment for urinary incontinence. And we observed that despite the majority of incontinence treatments being minor procedures, there was a higher risk of urologic complications when there was frailty present. So we revisited our conceptual framework and learned that in B, that there's this concomitant presence of urinary incontinence with geriatric impairments that characterizes the geriatric incontinence syndrome. And next, to operationalize this, we are taking this definition into clinical practice. And I'm running out of time. I want to leave at least a few minutes for questions. But this is kind of where we are right now. We are establishing the clinical care pathway for geriatric incontinence through a specialized clinical practice where women who are at risk, based on identifying them as having more severe incontinence, based on age, are being screened with a 4-meter gait speed. And from there, we are taking them through, we're developing evidence for the pathway to skip over the normal first-line treatments with pelvic floor physical therapy and move more towards more impactful treatments with procedures. Lots of other things to talk about, but I'm going to stop there and open up the floor for questions.
I get started, I want to commend Dr. Parker-Autry on a fantastic presentation. She is one of the collaborators, so is Dr. Bauer on the work I'm going to be presenting today. So thank you to them, and thank you to the Uro-Aging RIG for inviting me to share some of my work with you. We're going to start with an activity, and because I notice a lot of people have their cameras off, you don't actually have to do this, but just pose these questions to yourself and think about the answers. So in your head or to yourself, I want you to raise your hand if you get at least 150 minutes of moderate intensity or 75 minutes of vigorous aerobic physical activity per week. Okay, now I want you to hypothetically keep your hand up if you also, on top of that, strength train at least 2 days per week. All right, great. So you can go ahead and put your hands down. This is the amount of weekly physical activity that's recommended by the CDC and the American College of Sports Medicine. But how many adult women in the United States are actually meeting these guidelines? And I think this is an incredibly important question to consider, especially given Dr. Parker-Autry's presentation showing us that sarcopenia is one of the factors that falls into kind of that funnel model of geriatric incontinence. So unfortunately, data from the CDC suggests that not very women meet those guidelines. And we can see over time that this number is improving, but even if we're generous, only about 1 in 5 or 20% of women in the United States are meeting these recommendations. Why is this? The complete answer to that question is really beyond the scope of the presentation today, but relevant to our group, women have a pelvic floor problem that starts much earlier in life than some of the studies that Dr. Parker-Autry was presenting, but that certainly affect and contribute to the syndromes that she was discussing. So there were 2 really well-written papers that were published back in 2021 that included 4,500 community-dwelling women. And they found that about half of them either completely stopped or significantly modified their participation in physical activity because of pelvic floor symptoms like urinary incontinence and those caused by pelvic organ prolapse, which is going to be more of the focus of my presentation today. To begin thinking about how we address these problems, we need to ask what factors influence pelvic floor morphology or our structure and function across the lifespan. Before I present some of our findings from the study of muscle mobility and aging cohort, I want to introduce a lifespan model that was developed here at University of Michigan for our conversation. And I think I saw it in one of the slides that Dr. Parker-Autry skipped over, so we're going to cover it here. So this is our lifespan analysis of pelvic floor function. And here we can see our age on the x-axis and our hypothetical pelvic floor function on the y-axis. So we can see that in our younger years, we're building capacity in our system, our pelvic floor function is going up. And then during our childbearing years, we can have inciting factors, most consequentially vaginal birth, which causes a temporary dip in pelvic floor function that recovers, at least in many women. And then over time, that pelvic floor function declines for many of the reasons that Dr. Parker-Autry discussed, till at some point, a symptom threshold is crossed and women begin to develop symptoms such as urinary incontinence or pelvic organ prolapse symptoms. So we can see that vaginal birth and aging are 2 major factors that affect our pelvic floor function. Let's look a little bit closer at vaginal birth. Here we can see 3 hypothetical birth situations that are labeled 1, 2, and 3 respectively. Let's consider woman 1 first, which is the graph that we saw on the previous slide. So for this individual, she has a vaginal birth where we see this dip in pelvic floor function. We follow the dotted line back up. She has a full recovery and then has kind of this slow, gradual decline over time. Next, we can look at woman 2, who's had a vaginal birth with a slightly greater decline in function, which is kind of this dip right here. And maybe she had a minor or moderate birth injury that only partially recovers. And so we can see the rate of her decline, or the slope of this line, is the same as person 1, but we see that she crosses that symptom threshold earlier. So now she's having symptoms at around 60 instead of around 70. Then, unfortunately for woman 3, she sustains a major birth injury with precipitously and immediately crossing that threshold to where she starts experiencing symptoms around 25, never really fully regains that pelvic floor function, and remains symptomatic potentially across the lifespan. So we know that pelvic floor symptoms are a barrier to physical activity participation. So these injuries and their recovery are going to have different implications for these individuals in terms of when they may stop or modify participation in physical activity. Let's talk a little bit more about vaginal birth. So vaginal birth is really one of the most remarkable events in all of human biology. A 10-centimeter head has to pass through a 2.5-centimeter opening. So that's really like the equivalent of a watermelon being pushed out the top of a water bottle cap. In order for this to happen, the pelvic floor muscles have to stretch 3 to 4 times their original length. No other muscle in the body is capable of doing this without injury. So if we look at these openings, we can appreciate that there's really 2 different openings, or opening is also termed a hiatus. The levator hiatus, which is more proximal, and the urogenital hiatus, which is more distal. In some women after birth, these hiatuses remain enlarged. Well, that's a problem. It's a problem because hiatal enlargement is a precursor to the development of pelvic organ prolapse, which is the condition in which the pelvic organs descend into and out of the vagina. So you can imagine if somebody is experiencing this, they're probably not going to want to participate in physical activity, right? So pelvic organ prolapse most commonly presents with a symptom of a sensation of a bulge, but also patients report sensations of pressure or a feeling of heaviness, or like something is falling out of them. We can look at data from a 2021 longitudinal study that shows the proportion of women who remain free of pelvic organ prolapse as they age based on the size of their hiatus after delivery. And if we look at this red line first, we can look at somebody that has a small urogenital hiatus or a smaller opening. And with that smaller opening over time, they are less likely to develop pelvic organ prolapse even 20 years after delivery. But conversely, if we look at the individuals down here that have an enlarged hiatus that remains enlarged, the likelihood that they're going to develop prolapse and the rate at which they develop that prolapse is a lot higher. So in other words, a larger urogenital hiatus is an important predictor of future prolapse risk. So let's put that in context of physical activity. High levels of physical activity, which are a major determinant of skeletal muscle health and physical performance, are thought to increase hiatal size via repetitive exposure to intra-abdominal pressure. But high levels of physical activity are also associated with greater muscle health and full body health for aging individuals. So this paradox is really the driver of the studies that I'm going to present to you today, because we need to look at pelvic floor anatomy and comprehensive muscle measures to begin to try to explore this conundrum. During my fellowship and along with my collaborators at SOMA, we've asked a couple different questions to explore this paradox. So first, I want to walk you through some of our methods, particularly as it relates to MRI imaging measurements that we've used in all three of the analyses I'm going to show you, and then I'll discuss some of our results. We first looked at associations between hiatal size and skeletal muscle size, strength, and physical performance. So in this particular study, we used data from SOMA, or the Study of Muscle Mobility and Aging, which is a prospective cohort of community-dwelling older adults 70 years and older. And from this cohort, we analyzed MRI images and skeletal muscle testing data from a random sample of paras and all nulliparous females. From our MRI scans, we focused on the pelvis, as you can see here, using the 3D Slicer software to measure the urogenital and levator hiatus length, or anterior-posterior diameter, in the mid-sagittal plane. The urogenital hiatus was measured from the inferior pubic point at number 1 to the perineal body point at point 2, and then we measured our levator hiatus from that inferior pubic point to the middle bundle of the puborectalis, which is delineated with the 3. So let's look at our results. While nulliparous females had higher waist circumference and multimorbidity burden, physical activity level and all other clinical characteristics were similar between groups. Here we can appreciate the similarity, however, in our mean urogenital hiatus length and our mean levator hiatus length between nulliparous females in dark purple and our paras females in light purple. Now, for those of you that are clinicians, this might be surprising because we would think that hiatal size would be larger in our paras women given the data I presented earlier, but we'll come back to this. Using Spearman and partial Spearman correlation coefficients stratified by parity status, we found that in nulliparous females, none of the 7 skeletal muscle measures were associated with urogenital or levator hiatus length. However, in our paras females, longer 400-meter walk times, which means that they were walking slower, were associated with a greater levator hiatus length. So on our scatter plot here, we can see that as walk time increases on our x-axis, that our levator hiatus length increases on our y-axis. And roughly for about every 10-second increase in walk time, hiatal length increased 1.2 millimeters. Now, if you think back to the clinical significance of that, we saw that for every 5 millimeter change or increase in hiatal size, that affected when and if the prolapse risk increased. And while numbers vary a little bit, for women completing the 400-meter walk test, which is a quarter mile, if they did it in 400 seconds or more, that indicates that they had an impaired functional capacity. So we can see a lot of these women that have larger hiatuses are pretty impaired functionally. So what are our key messages from these findings? Slower walking speed was associated with a greater levator hiatus length in older community-dwelling Paris women, possibly suggesting either greater risk of pelvic organ prolapse in deconditioned Paris women, or that symptoms of prolapse may prevent physical activity or be a barrier to physical activity, thus leading to a deconditioned state. Next, we wanted to look at hiatal size across the lifespan, not just in older women. So in this analysis, we included women from SOMA as well as those from SOMA Junior, which is a cohort of women 30 to 69 years old. And similar to our first analysis, we also considered interactions by parity status, given the effect of vaginal birth on hiatal size. We hypothesized that increased age and parity were both associated with greater hiatal dimensions in community-dwelling women across the entire adult lifespan. In this study, we used the same MRI measures that I showed previously, in addition to these measures of hiatal area. On the left, we can see the levator bowl area, and on the right, we can see the levator hiatus area in the plane of the levator hiatus. Now, our levator bowl area has been shown to estimate bowl volume, which is what we see here, quite well. And we know that in women with prolapse and with aging, that bowl volume, which represents kind of a sagging and a descent of the pelvic floor, is larger. And so we can see as we move across the screen that we have our young nulliparous individual over here, moving to our older multiparous women, and then a woman with prolapse. And what I really like about this image is it overlays a woman that is older with prolapse in red, so the most significant change, over our healthy nulliparous individual in black. A lot of the area that's been performed a lot of research that's been performed in this area has been in populations that were selected for pelvic floor disorders. So something unique about our studies were that we were looking at community-dwelling women who were not specifically selected for this. Let's look at our results from this study. Here you can see the associations between each of our 4 morphology measures on the y-axis and age across 6 decades on the x-axis, with our unadjusted beta coefficients represented by the black line and our 95% confidence intervals represented by the gray shading. And so what this tells us, for example, if we look up here at the box in the upper left, is that we can see for every decade of age increase, our urogenital hiatus length increases by 2.04 millimeters. When we ran a sensitivity analysis, we found a possible age by parity interaction for levator hiatus length, which is why you can see this stratified out by parity status for our levator hiatus length. So we look at all that, so what? Why do we care? Our key findings from this was that resting urogenital hiatus length and levator hiatus area were greater in those with greater age and community-dwelling women, regardless of parity or levator injury status. So from this, we can see that aging plays a significant role in pelvic floor morphology changes across the adult lifespan in community-dwelling women, independent of parity and body size. To end today, I want to show you some of our preliminary analyses that focus on associations between physical activity and pelvic floor morphology, now going back to just our older women in the SOMA cohort. Before I get into the analysis, I did just want to show you a picture of this actigraph. This is a wrist-worn accelerometer, which is what was used in the SOMA study to measure our physical activity. When we think about physical activity, especially me as a physical therapist and a substitute CrossFit coach, I always have to think about the different elements of physical activity. So here we need to consider both the volume of physical activity, or how much cumulative activity is performed, as well as the intensity of that activity. I just want to briefly remind us of the paradox that I discussed at the beginning of the talk, that we're still uncertain of how physical activity affects the pelvic floor, because we have some evidence that increased physical activity has been shown to increase pelvic floor muscle strength and size, but that it also places greater strain on the pelvic floor structures. So in this study, we hypothesized that decreased physical activity volume, which was an overall lower daily step count using that wearable accelerometer, is associated with greater age-related changes as seen in imaging-based pelvic floor morphology in a manner consistent with other muscular and passive tissue body structures. We also hypothesized that increased time spent in higher intensity, which we classified as moderate to vigorous physical activity, is associated with less age-related changes as seen in imaging pelvic floor morphology in a manner consistent with how other muscular and passive tissues in the body respond to loading parameters. We didn't find any interactions by parity in this particular cohort, so we considered all of our SOMA participants in a single group and stratified them into tertiles based on their daily step count. And so when we stratified by tertile, the women in the highest tertile were younger, had a lower BMI and waist circumference, were less likely to have undergone a hysterectomy, were more likely to not have any chronic conditions, were less likely to be a smoker, and participated in more physical activity, both higher intensity and total volume, compared to those in the lower tertile. Our linear regression models that are shown here for 115 women, 70 years of age and older, based on both our mean daily step count, which is our physical activity volume, and our mean exercise intensity, which is our moderate to vigorous physical activity in 60 minutes per day, were not significantly associated with any of our pelvic floor morphology measures. However, if you look at some of the confidence intervals, they do include some possible meaningful effects. So what are the clinical takeaways from this? Neither physical activity volume nor intensity was associated with pelvic floor morphology in older women, suggesting that physical activity should not be discouraged to prevent changes in morphology and later pelvic floor dysfunction. There are already so many barriers to participation in physical activity for women, for older adults, and then for that intersection of older adult women. So ill-informed but well-meaning advice from pelvic healthcare providers should not be one of these barriers. Finally, none of this work would be possible without my incredible mentors, my SOMA collaborators, and generous funding from the NIH, but really most importantly from the SOMA participants. So a big thank you to everyone here. And with that, I will go ahead and stop my share and open the floor up to questions and more dialogue.